Good evening, one and all. Welcome to ROS Case Files 2. We will be having 3 cases. First will be presented by Dr. Dhruv Worah. He will be speaking on the lost IOFB. Second will be Dr. Harshal Baldha. He will be speaking on phaco in a small pupil. And after that, Dr. Devyani, she will be speaking on cases of corneas, the Jacqueline and height of cornea. We will be honoring our stalwart Dr. Rekha Madam after the 3 cases. So without wasting time, we will start our first case. I would like to share his screen. Dr. Dhruv, you can start your presentation.
Of course, Dr. Dhruv needs no introduction. He's a prolific vitreoretinal surgeon in Rajkot and doing great work. So we'll see some of his surgeries, I think videos he has today. Dhruv, please.
Thank you, Powal sir. Thank you, Suketu Bhai and Team ROS for giving us this opportunity to meet virtually. Today, I'll be presenting a case which did not go the way that it was supposed to. Usually IOFBs, especially if they are metallic and magnetic, it's a treat for the VR surgeon also to do. Seeing the outcomes, if the foreign body has not affected the fovea, usually the patient has a good outcome. These are a gamut of 4 or 5 cases that we have done in the last year or so. Usually the procedure involves doing a vitrectomy, removing the foreign body through a superior limbal or a sclerotomy incision, and doing some laser and maybe giving a tamponade if required. So the case which I am going to present is of a 28-year-old male who came to us during this lockdown on 14th December 2020 to be exact, with history of workplace injury with a metallic foreign body about 2 hours prior to presentation in the left eye. The right eye was within normal limits with good vision. The left eye had vision of 660 and 18, and there was a small self-sealed tear at the limbus that was noted at 4 o'clock in the left eye, and the lens was clear. The fundus showed some vitreous hemorrhage with some yellowish spots seen at the fovea. It was very hazy view because of the hemorrhage, and the B scan showed the classical double optic nerve head because of the reflectivity of the metallic foreign body. The patient was advised surgery the same day and also advised CT scan just to confirm the location of the foreign body. And he underwent the surgery after a day after he was advised, that's on 16th. So going to the video, it's imperative to seal this small tear since the IOP fluctuations during surgery might cause it to leak, and then suturing it might be a little difficult. We started with 3-port 23 gauge pars plana vitrectomy. The vitreous hemorrhage was cleared. You can see the yellowish spot that is seen at the fovea, which might show the site of impact. That is just a small exudate that you see in the corner. On doing further vitrectomy, I was just trying to localize or search for the foreign body since it was shown to be metallic on CT and on the B scan. PVD is being induced. Vitreous hemorrhage makes it easy. It obviously stains the vitreous, and it's very easy to visualize the posterior hyaloid which is being detached here. One needs to be sure to go along the surface of the retina so as to not create any further traction on some weak points in the retina if there are. Further completion of the vitrectomy was done, including amount of base shaving which was safely possible with the clear lens. Then came the main challenge. Even after clearing this vitreous heme, one sees just a few exudates that are located at the fovea and near it. I tried to and see if there is anything below it so as to remove. There was nothing that came. This peronasal sclerotomy, I enlarged it to 20 gauge, trying to just put a magnet and see if some foreign body which is there localized on CT and on B scan but nothing was coming up. So now I started getting a bit tensed, searching what to do. I tried to see if the foreign body was dislodged anywhere else. The other place obviously is to check the pars plana region. So 360-degree we tried and depress the pars plana, but unlucky not to find any other foreign body. This is just the small snippet showing the depression 360-degree, which is a must to rule out peripheral regions and to locate the foreign body. Not seeing that there was no other foreign body, what I decided was to just insert a big 18-19 gauge magnet that we have, and I considered it to be subretinal, hoping that with the pull of the magnet it might just pop out from the point of entry, whichever it might be. But again, there was nothing that came up, just a small speck of heme, which I cleared and decided to prod on, considering that the visual outcome, since it involves the fovea, is guarded. There you see a small hole-like thing just below the silicon tip of the back flush. I just had a weird thought that being a very small foreign body, whether it had just exited through the fovea. Again, just tried to put in the back flush, activated the active suction, trying to pull out if something is stuck there below the RP or subretinally or in the sclera, hoping that it might come out. But nothing in the end, nothing came out. I just did a fluid hair exchange, sutured the enlarged sclerotomy that I had created, and finished or closed the case after doing 2 rows of peripheral laser, and then going ahead with injecting SF6 gas, and also injected intravitreal antibiotics, vancomycin and ceftazidime, seeing that there were exudates at the fovea. I would like to share the fundus photo next. Yeah. So the patient underwent the surgery on 16th December. This is about 15 to 20 days after the surgery, with some amount of residual gas that can be seen. On this is 15 days later. After that, you can see scarring and resolving of the exudates. And this is just yesterday. The patient had come for a follow-up. The exudates have totally gone. One can see some scar involving just a part of the lower part of the fovea. Going on to the B scan. This is on the left is the pre-op B scan, which shows the foreign body. This is post-op about day 15 after the surgery, showing that the foreign body is still there. The echo surprisingly tend to are coming from the anterior surface of the retina, but there was no foreign body localized there. On further proceeding with I tried to do the OCT, and one can see that sliver-like foreign body in the subretinal or the sub-RP space subfoveally. And the last OCT does show some amount of choroidal neovascular membrane that's developing and involving the subfoveal space. The angio OCT done on the last visit, that is yesterday, does show a CNVM subretinally. So this was a case which I had not anticipated that these things would turn out intra-op like this. I would just like to ask the panel if there is anything that I had missed in assessing, and if I could have done something to remove the foreign body from that space, and what to do so as to not re-encounter such a situation. Thank you.
Yeah, very well documented case through. Yeah, it's a difficult situation, both in terms of location of the foreign body as well as the depth. Correct. So it becomes difficult when you have to prod on the foveal area. Yeah. Did you do the CT scan post-op?
Post-op, I have not done it, sir.
Okay. Yeah, sometimes it happens. If it is deep, you will not be able to get it out. But the technique of removal, like you should, in my opinion, use a harder tip, correct, not the soft tip. Okay. Hard tip, extrusion cannula, for example, and that sometimes gives you a feel, okay, that something is metallic is touching the thing. Then maybe you can make a small nick in that capsular in that fibrous capsule, fibrous element or exudate, whatever is there,
Yes.
and a corner of the foreign body may peep out.
Yes.
But it is easier said than done because the location is such that you don't want to damage more.
Yes.
I understand. So you can't keep doing that. And yes, and the other point is whether it was magnetic or not.
Yes, sir. That's what.
So if it is non-magnetic, obviously you cannot, the magnet won't help. So that also you need to confirm what was the exact nature of the foreign body. Most of the time it is magnetic, it is iron, but sometimes they are working with other metals. So,
since the vision, sir, from 660 and 24, it had improved to 624 and 10, 15 days after the surgery. So, and the OCT showed a foreign body in that space. So I didn't ask the patient to do anything else.
Dhruv, had you tried it from the scleral side? Like, was it subretinal but subscleral also?
No. It on the OCT it shows subretinal or at the RP level, but being at the fovea to reach there from the scleral side.
Scleral side, it is impossible.
Yeah.
No. Just blindly going to the side where the fovea is with a magnet, externally, and if the foreign body is slightly projecting on the scleral side, then it can come out. But as your OCT show, I don't think it has penetrated the sclera.
No, sir. Even the CTC showed it to be intraocular, in the codes.
Yeah, it was under the sclera actually.
Yeah, the sclera was not breached posteriorly.
Sclera was intact.
Yes.
Did you have the CT scan picture?
I don't have, sir. The patient, they had not brought it yesterday, so I could not.
Right. I understand.
Do you think this patient is likely to get into siderosis because it's not a classic double perforation?
Yeah.
So will the patient get siderosis?
So that's why I have been following up. I called him after 2 months of his surgery. Still, vision is good. There are no other signs of pigment dispersion or anything there. Just the CNVM developing because of the impact in the choroid. I've advised him an anti-VEGF injection, which I think he wants to come after a month and then decide.
Right. Siderosis probably is unlikely now that the foreign body has exited from the retinal side at least. It is subretinal, if not deeper than that. So probably it has been walled off from the retina. So siderosis.
You can't say actually, because it can take years and years. You really don't know.
Yeah, but at least right now it is.
You must keep a close follow.
Yeah. Yeah, interesting. And how did the patient take it?
Yeah, the patient is pretty happy because the vision has improved. He's been informed that the foreign body has not been removed because it is in such a location where removing it might cause further harm to the vision. That has been explained clearly. And the need for more frequent follow-up, then maybe 6 monthly follow-up after some time has also been explained. And let us see how we
I've had brass foreign bodies, which I can see it there, but you can't remove because they are large and you can't hold them. It's non-magnetic. Sometimes it's a tough situation.
So he was working on a bike, sir, and he was sure it was some part of the iron nail.
Yeah.
That is why. Otherwise, there was another foreign body which was like you say a copper rich thing which gives a metal like echo, but again it's not magnetic. So that was what I was thinking might be.
No, it could well be iron, but it was impacted deep enough so that it couldn't come out. Yeah, good case. Thank you.
Thank you, sir.
Right. We'll move on to the next presentation by Dr. Harshal Baldha, who is a very senior phaco surgeon, having done thousands of cases now, I suppose, and quite skilled, quite fast. And now he's going to talk on small pupil phaco.
Good evening, everyone. You can see the presentation, huh?
Yes, sir.
Okay, I don't know where this comes from. And we'll start from first. Okay, this is a presentation I had prepared in 2016, though I updated it now. It was meant just simply to give an idea of the instruments and the techniques available for dealing with a small pupil phaco case. So I actually had started this one as a case report for a difficult small pupil phaco surgery. Now I'll just go through the case report very quickly. It was a male 84 years old who was diagnosed as glaucoma and cataract, diabetic, hypertensive, ischemic heart disease, CABG, everything you can think of. And his vision had gone down sufficiently that he wanted surgery. He had nuclear cataract, grade 4-5, and the pupils were very small, not dilating beyond 4.5. His CD ratio was 0.7 because there's known case of glaucoma. So the plan basically was to do both eye phaco with IOL, with patient's choice of IOL. Viscoat would have to be used to protect the endothelium, considering that the cataract was very hard. Pupillary dilators were kept on standby. That is, I used to use iris retractors at that time, so I kept the iris retractors on standby. I had modified my phaco technique to use 2.2 millimeter 45-degree phaco needle with 2.8 millimeter sleeves to get better flow and better antechamber stability. I was doing the surgery on topical, but I kept the block ready. And I also checked that the VR surgeon was in town in case I have any difficulties. I kept spare IOLs, backup IOLs in case there is a PCR or anything like a large diameter PMMA or an SF IOL. And I also kept anesthetics as a backup. The best part was the patient was cooperating, understanding, counseled thoroughly. Negative, it was a hard cataract in a small pupil in an aged patient with glaucoma, diabetes, ischemic heart disease on multiple drugs, and I had to do both the eyes. This is a little, I've done the surgery. Are you able to see the surgery? Can you see the surgery?
Yes, sir.
Yeah.
Okay, I'll just go quickly through it just to give you an idea of the small pupil. This is a small pupil that I had faced. You can see it is about 4.2 to 4.4 millimeter, not more than that. I did capsule staining. This is a capsular staining. Did the axis using a forceps, and I went under the edge of the pupil to get a better, larger axis. And then I did a routine phaco. It was difficult. It was a bit long. It was a bit long. Surgery was a little longer, but finally I was able to put the lens without any major issues. And in this case, I did not use any of the, pupillary dilating mechanisms, either the techniques or instruments. Just did it to the small pupil that I had. This is the IA part, and then I put the IOL also, and the patient was doing well post-op. I won't go into the much details of that one because, and this is the post-op photo, day one. He was doing it, last I saw him was doing quite well. These are the details of the case. Theoretically, a pupil is considered small if it is actually less than 4 millimeters actually. But nowadays, a pupil of less than 5.5 is also considered small because you can't do a proper CCC if you're using a femtosecond laser. The incidence, though they say it is 1.6%, but if you are a senior person and you are doing lots of difficult cases, then quite a lot of your patient, maybe more than 5% would be with small pupil. And considering that diabetics and everything are increasing, you are bound to face more and more of small pupil cases. Now, these are the common cases of small pupil, age, diabetes, miotic, use of miotic, etc. But what I would like to highlight over here is intraop floppy iris syndrome. Tamsulosin is one of the drug, alpha-1 adrenergic, which has been antagonist, which has been said to be cause this syndrome. But just for information, it is this tamsulosin is given not only to male patients, elderly male patients for prostate, but I have recently found that it is also being used to give to females for urinary tract issues. So both males and females can come with this intraop floppy iris syndrome, the small pupil with a very elastic iris, which can come in your phacoprobe and make it a very difficult surgery. We are afraid of a small pupil simply because of the difficulties in the surgery and the compromised results. Management basically is pre-op. Now, naturally, any pre-op assessment, when you do a dilatation, will know that this patient does not have fully dilating pupil, so you should be prepared. to deal with the small pupil. So where you can intervene is pre-op pupillary dilatation, intra-op pupillary dilatation. So there are, in case of intra-op pupillary dilatation, we have various pharmacological surgical procedures and pupillary dilator devices. This was the thing I wanted to focus more on when I was presenting this. Now, pre-op dilatations, these are some of the things you can do. You can stop myotics 2 weeks before. Stopping alpha-1 antagonist, that is tamsulosin, has no effect. Even a 2-week course of tamsulosin tends to affect the iris somehow such that it's going to cause floppy iris syndrome inside the eye. You can dilate with tropicamide. See, the dilator which has tropicamide with phenylephrine has 0.8% tropicamide and phenylephrine 5%. So you can take them separately, tropicamide 1%, phenylephrine 10%, and if necessary, cyclopentone 2% to increase your dilatation. And naturally use NSAIDs like flurbiprofen to stiffen the iris. Neparfenic is supposed to be better than flurbiprofen in stiffening the iris. On table, this is something that we used to use earlier when we were in residency days. I call it desi sudiraken, which is subconjunctly given near the place where you want the pupil dilated. It's lignocaine 2% with 1 drop each of epinephrine 1:1000 and atropine without preservatives. You can give it subconjunctively before the surgery. It might dilate it. But remember, these are the things which go systemically also, and you should take into consideration the patient's systemic status also. Intraoperative, there is a wide range of pharmacological and mechanical pupillary dilatation devices. One of the new ones is the phenocaine plus. Otherwise, we have episugaracane, and early on we also used to use epinephrine in BSS, that is Epitrit now, that is available commercially. We can go for viscomydriasis, posterior synovitis. These are some of the surgical procedures we do to get a larger pupil. We have pupillary membrane dissection, stretched pupilloplasty, a very brutal method. Mechanical pupillary dilatation devices in iris surgery also. This is one commercially available preparation which is used for dilating the pupil on table, and the results are quite good. Can you see the video, please?
Yes, sir, we can.
Yeah. This is how it is seen. This is Dr. Gaurav Luthra's video. He has put the phenocaine and see within 10 seconds quite a bit of pupil is dilated. Now this is a pigmented eye and this is relatively non-pigmented eye, and even that one the results are quite good. The results speak for itself. Now we put a little bit of viscoelastic, you will get sufficient dilatation of the pupil. Then there is the episugaracane. The recipe is, if you want it, let me know. I have the details over here. It's the same. You use it the same way you use phenocaine, except that in this one you have to make it. The phenocaine is directly available commercially. These are the effects of episugaracane. That again, the results are quite good. Just watch the pupil dilating. See the effect. And after that, you put some viscoelastic and you'll be able to get a sufficiently dilated pupil to do your surgery. Right? That's good. That's good dilatation. And this is just an image of using viscoelastic to dilate the pupil. This was a video of posterior synovitis. Unfortunately, I could not find it. And this is another one like that. This is pupillary membrane dissection. These are all videos that I picked up from YouTube. Some of them are mine, but most of them are from the YouTube. He uses a scissor to cut the pupillary membrane and then uses a forceps to remove the pupillary membrane from the edge of the sphincter. That allows it to dilate. And after that, you can use any of the techniques like pharmacological mydriasis using phenocaine or maybe viscomydriasis also. This stretched pupilloplasty, a pretty brutal method that you can use to dilate the pupil when if you don't have anything on hand. Simply you can use two dilators to dilate the pupil. You can use two Sinskey hooks or things like that. It's just you stretch the pupil, you tear off the sphincters and allow it to dilate. Then you use the viscoelastic to dilate the pupil and keep the pupil dilated while doing the surgery. Very brutal, but there was a time when these pharmacological means and pupillary dilators were not available. We used to use this. You can see the amount of dilatation which is available after stretching the pupil. The dark circle is that trypan blue stained area, which was before the pupil was dilated. Now, this is a Bayerless pupillary dilator, again a mechanical dilator of the pupil. You can see it at work in this video. These are just some various means available for you to deal with small pupil. There is a hook which he hooks below the, over here there is a hook which he hooks below one edge of the pupil and then uses the three prongs of that instrument to dilate the pupil, to stretch the pupil. I thought, what else would he do? But when I saw the video fully, he turns it and then again stretches on the side and this side also. So it gives quite a good stretch. But again, as I said, a pretty brutal method and to be used only if you feel it is absolutely essential. Okay. Something similar is the same thing, but in another case. Now he's using that.
Harshal, which is the best device according to you currently?
None. But I think B-hacks that we have is, I think, supposed to be the best. I'll come to it soon. But these are just some of the things which are available. If you have nothing else, even you can use some things like these. Now, mechanical pupillary dilatations, as I was talking about, we have iris hooks, which I've used quite extensively. Unfortunately, I do not have any videos about that. There are Morcher pupil dilator, Kushner's perfect pupillary dilator, Maljugening, APX 200. But the recent one is the B-hacks, which is a made in India, make in India. I will go to that first. This is the B-hacks. Actually, it's a hexagonal. And a hexagon is supposed to be a very strong shape, giving quite a lot of support with a lot of perimeter area. This is one of the quite large perimeter area. And if you want to see it at work, this is one of the best videos I picked up from YouTube. I do keep BX as a backup, but fortunately or unfortunately, whatever way you put it, I've not been had the chance to use it yet. This is the BHEX. Suvin Bhattacharya, Dr. Suvin Bhattacharya's invention. And he puts quite a lot of videos on YouTube. You should take a look. It's very interesting. There are various techniques. You can also use a Sinski hook or something like that to tuck these flanges of this BHEX. As you can see, it has quite a good area of pupillary dilatation to do a proper surgery. And very simple to place and very simple to remove. But still, if you consider all the pupillary dilators like these ones, you do have to manipulate quite a bit. These are the iris hooks. I'm sure most of you have used it. These are titanium iris which Macul used. And this is just a photograph of iris 6 hooks in use. There are certain advantages and disadvantages of using these hooks. I'll not go into the details of it because most of you know it. This was something interesting I found on the net. You can make your own iris hooks in case you are stuck using a thick proline suture if you have that ready also. But generally sterile are available. The only thing is you have to heat it up. Here you can see you have to heat it up to get that curve before you use it. But it's just something that was interesting. This is Morcher's pupillary dilator. Device may be a little similar to BHEX, but a bit unwieldy, I feel, a little thick and unwieldy. If you look at that, a bit thick. See, look at this area. It's a bit thick as compared to Suvin Bhattacharya's BHEX. And this is how they use it. Then after putting it inside, it's just tucked in to dilate the pupil. As you can see, just like BHEX, even this one, the manipulation is even more than as compared to, say, what was shown in the BHEX. You have to be quite proficient at moving inside the entry chamber to use these things. See, quite a good dilatation, circular dilatation in this case. And removal. You just take it out from under the pupillary edge and remove it. Again, same. This is Kirshner's perfect pupillary, similar to that one, so I have not put the video. This is Malaysian ring. This was amongst, I think, the earlier pupillary dilators available. And this is injecting it. But as you can see, every time in all these cases, you have to do quite a lot of manipulation if you want to use these dilators. See, every time you hook it up, put it below the edge of the pupil, and same for all four sides. And that's the end of the surgery. He has completed the surgery. Now he removal is relatively easy in this case, but again, manipulation is required. This is another interesting, just two forceps they used to dilate. I found it interesting, so I placed it. I don't know, I haven't used it. So I don't know if somebody has used it, they can always share their, this is how it is used. You make side ports and push it from inside through the side port and just like a forceps. And catch hold of the iris and dilate it. That's it. Removal is as simple as you just remove the
speculum inside the eye.
Yeah, it's like a speculum inside the eye. And there are certain problems with surgical pupillary dilatation, irregular pupil, iris anticapsule injury, posterior synechiae, intraocular inflammation, which you have to deal with. And there are studies of pupillary function after iris, and most of them say that there are difficulties in the pupil. You can always make out that this pupil has been injured. I mean, this iris has been injured. But these are something that pupillary function after cataract surgery using flexible iris retractors in patient with small pupil by Tamagi Yugichi and others. The conclusion was the inappropriate use of flexible iris retractor causes an atonically chronically angled posterior. Now, this is something which is faced by any mechanical procedure you use to dilate the pupil. So you have to be ready to face it. These are the photographs of them. You can see the iris hook impressions. You can see the distorted pupil. But so long as the patient has good vision, I suppose it's all right. These are some of the iris surgeries that are used, which I don't know if anybody is using now. Now, a little word about the intraoperative floppy iris syndrome. Pupillary stretching is not effective. It's preferable to use pupillary dilators. I mean, these Mulligan rings, BHACs, things like that. Personally, I have faced these kind of cases. I prefer to use dilators. I mean, pharmacological dilators and use of higher OVDs like Viscoat and Hilon to keep the pupil dilated and do the surgery through the small pupil. Now, this was an interesting study. I prefer to do small pupil. In case of small pupil phaco, I prefer not to touch the iris and prefer to do the phaco at a posterior level and without using any means, I mean, pharmacological or dilator. And I found someone who shares my thoughts. He prefers to work through a small pupil on a posterior plane, and he describes the technique of doing that. So there are people like me who prefer not to use anything when dealing with a small pupil. These are just some recommendations by the Royal College of Ophthalmology. This is actually September 2010, but they are quite pretty practical. This one you see small pupil, other than above, you can see viscomydriasis, pupillary stretch, sclerotomies, iris hooks. So it's just a good book if you want to refer. Now, basically, as I said earlier, the take-home message when dealing with this, these kind of pupil, this was actually meant for my juniors. I told them to counsel the patient thoroughly when you're dealing with a small pupil, because there is a possibility you might face quite a lot of inflammation. It might take a long time for visual recovery and everything. That everything has to be explained to the patient. Dilate fully using higher concentration mydriatic, like I said, tropicamide 1%, phenylephrine 10%. Prefer to use either subconjunctival intracameral dilating pharmacological agents like epinephrine in BSS, or even you can use phenocaine also. prefer a small slow motion phaco like Robert Osher through a small pupil. You're working on a plane lower than I generally prefer in normal phaco, I prefer to work at the level of the iris. But in this case, I have to work inside the bag, endocapsular phaco. And you have to do very slow so that you don't make, complicate the surgery. That's why you have to do very slow phaco. And prefer to use viscomer, lots of higher end viscoelastic to keep the pupil dilate. You can dilate it, do the surgery. As soon as the pupil go down, you can again put the viscoelastic and again dilate it a little bit, again go for the surgery. That's the best way. That's why it takes a lot of time, but the results are worth it. And worst comes worst, you can always use mechanical pupillary dilators and iris surgery in desperate cases. In uveitis, generally the pupils are down because of pupillary membrane. So synechial and posterior synechial. So synechialis and pupillary membrane dissection will definitely be required. After that, it is up to you to what to use further on. And IFIS and iridoschisis, again, I prefer only viscomydriasis, and in desperate dire cases, mechanical pupillary dilatation or using of pupillary dilator devices. Other measures, as I said earlier, higher end OVDs. You can give a block also. Block itself increases the dilatation of the pupil. And always have vitreoretinal backup because you never know what you are going to face. Post-op, lots of steroids, cycloplegics, and yes, lots of counseling of the patient. That everything helps. I would like to thank all the contributors on YouTube whose videos I used to demonstrate the various techniques and instruments. I thank you all for your patient hearing. Thank you.
Thank you, Harshal, for the elaborate presentation. Yes, we'd like some quick comments before we move on to the next case. So, what are the devices which you have actually tried?
I prefer to use, I have done mechanical dilatation and iris hooks. I've kept BX ready because amongst all the dilator, pupillary dilator, I found BX to have the least minimum difficulty in placing and removing, though I haven't personally tried it. But I think BX is a good option if you want. Now I have to try phenocaine also. But otherwise, if you ask me what I've used primarily iris retractors, mechanical stretching of the pupil, viscomydriasis, and generally I prefer not to use anything, just work through the small pupil. That is my general standard procedure.
How small can you work through?
I've worked through a 3.5 millimeter pupil. That I think is the smallest one. Otherwise, I just stretch it. The mechanical thing. It's a bit. I know it's a bit brutal, but it's quite effective.
One thing about the devices, this BX is uniplanar, very thin, single plane. Thin. So probably
it is in two planes because flanges are up and down. So actually, it is two plane, but it is made in one plane. It's like that.
It becomes two plane when it touches the iris.
When you put it inside, yeah.
So it is easier to softer on the iris and easier to handle if you learn to.
But anyway, when you stretch the pupil, it's bound to cause some injury to the iris, and that is going to reflect later on in the post-op period. You might be able to see it also. If we वहाँ पे sphincter stretch tear hai, you can see it also. If you are a good discerning ophthalmologist, you'll be able to see it. But still, it's a good something. I mean, something is better than nothing. It's better to have an uncomplicated case using this kind BX or something like that, rather than a complicated case and not using this.
Other thing is the phenocaine is not a substitute for mechanical devices. Pharmacologically, it will work.
It will work.
Your pupil is going to dilate.
If it is going to dilate, it will dilate with the phenocaine. Then you might not have to use, or you might use simple viscomydriasis. The only thing is nowadays what they do is they don't dilate the pupil at all preoperative. Take the patient on table, put phenocaine, operate the patient, and then let him.
That's why
no preoperative topical dilator.
Lignocaine also, I think, for the anesthesia effect.
So there is lignocaine there.
Yeah, I think you have covered the topic extensively.
Question, sir?
Yes, Dhruv. Yeah.
Sir, you told you prefer to use mostly viscodilatation and not any other devices. If the cataract is, say, sort of soft and you have loads of cortex, do you not face any difficulty during cortex removal?
I use that Sinsky to pull the iris and then go down and take the piece. I do it all 360 degree around. I have done that. If I have a video, I'll share it sometime.
Right.
On the same side, you can use the Sinsky hook. On the opposite side, you can use that IOL dialer because it has a flange So you can push the iris and then pick up the cortical lens method.
Right. We move on to the next interesting case, titled, interestingly, thank you, Harshal. Titled also interestingly by Devyani, the Dr. Jekyll and Mr. Hyde of cornea. Let's see what she's putting up with.
Thank you, sir. Thank you always, ROS, for being so supportive and encouraging. So this is a situation that as a corneal surgeon, I have faced, corneal physician here, I have faced over and over again, as in that I have always faced this duality that I am sure is present in everything in nature, like the yin and yang, the Dr. Jekyll and Mr. Hyde, and there are multiple facets I'm going to touch upon here. What we are going to explore today is how the nature of the corneal finding itself is different under different circumstances. It's a crystal ball of possibilities that we are supposed to unravel. The duality of the medications that we used, each medication can be a double-edged sword, varied presentations of microbial keratitis and what to do when. So just without further ado, this was the case I saw just this morning. In fact, I replaced it the last minute. A 60-year-old gentleman, 1.5 months post cataract surgery in the left eye, done at our place. He had 6/9 vision leading up to today. When he complains of a sudden drop in vision since few days in the operated eye, he was very happy the last time we saw him. He has the complaint of watering. Other than that, he's fine. This is the picture that he came to us with. More or less okay looking cornea, AC looks quiet, IOL is in place. There's some sort of a haze on the cornea, but probably something he already had. When you look closer, you see, okay, there's some pattern forming here. Probably better to stain it and see. When you stain, you realize there's a dragon sitting on the cornea, and obviously his vision has dropped to 660. And there's the reason why. Here we had the benefit of having seen him before and treated him for viral keratitis. So it was really high on my suspicion list to begin with. But these are the cases which will really, the cornea will fool you. And when it comes like this and it actually is this, it's difficult for us to know unless you have the right filter on, so to say. This is another case, 40-year-old lady, poor vision for many years, suffering from pain and irritation for 1.5 months. Eye looks kind of quiet, but she has a lot of complaints. There is a lack of obvious infiltration, yet there is a leash of vessels. Now, to have a leash of vessel coming into the cornea without any actual infiltrate that it is trying to treat, how viral of you indeed. So we went ahead with appropriate oral and topical medications for viral keratitis, and this is at presentation and this is 2 weeks later. So what do we learn? We learn that lack of infiltration, a vascularity in the absence of infiltration, thinning of the cornea, and a chronic history. All of these things are indicative of viral keratitis in this patient. Okay, now that we know this, probably it will help us when we see another case later. So then this case comes up, and there are a few things in favor, few things against. Whatever we have observed, we find out it's a chronic history. There's a hypopion here, but there's vascularity, all right, but there's a lot of stromal necrosis. So what next? Is clinical diagnosis fine here? Is it okay to, put all medications on this patient? So we went ahead and did a scraping for this patient. Whenever in doubt, scrape is what we were taught. So we scraped, and this was more like a diagnosis of exclusion, because everything, bacterial, fungal culture, sensitivity, everything was negative. With this kind of suppuration in the cornea, you don't expect it to show nothing, especially if you've done a good job with the scraping. So we started her on antivirals or topical steroids, oral antivirals. This is the picture 7 days later, probably 5 days, I'm not sure. The hypopion is gone. Infiltration is much lesser. However, you're ending up with a thinned out cornea. So again, here we deal with the duality of the steroids that we love in viral keratitis, is how it leads to the thinning as well. While it causes your hypopion to disappear, your vessels to regress, your stromal infiltration to go away, but it will also take away with it healthy stroma. That is kind of, it melts away. We do a glue BCL. The patient is doing well at the end of the story. This is the fourth case. which was a known viral disciform keratitis treated 4 months back. Now, the previous case, we saw how steroids saved the day and we were able to give the patient a quiet eye at the end of it. So this patient, thinking the same thing, that these are the medications that are helping me, continued to put dexamethasone eye drops once or twice a day since the time he had that viral keratitis. This is how he reaches a colleague of mine. And looking at this limbus to limbus infiltration and having no tissue backup, that colleague sent it to me. And my first reaction was, it's a secondary infection, fungal keratitis, therapeutic keratoplasty is inevitable. When I calmed down after this, I realized it's a proven history of viral keratitis. Local immunosuppression by steroids is a known trigger for viral. Let's calm down and proceed with microbiology. Similar results we found, and this is over a period of 2 weeks where the eye has quieted and we have prevented an unnecessary and bound to fail therapeutic keratoplasty. And again, glue-BCL helps us save the day. What we have learned over these 4 cases, I have realized, is that we learn with each case. And these are 4 very different yet similar presentations of viral keratitis. We stumble regularly. We have a constant battle of wits with the cornea, where the cornea is trying to outwit us all the time. Microbiology is kind of our backup, and it also has a role of exclusion. While the double-edged sword we handle of topical steroids scrapes us regularly, we still carry on with bandaged hands. So thank you so much for your patient hearing. I hope it was
excellent. Excellent collection of cases, Devyani.
Thank you, sir.
And presented very well, fluent and lucid as ever.
Thank you.
Right. Yeah, I don't think many people will have much to comment on them.
No, but anyway, you are always, afraid of giving steroids in cornea. Only you people, cornea people can give. We can't give that. We cannot take that risk.
So we also put the responsibility on microbiology.
I'm presuming that you must also be feeling afraid when you're getting steroids.
Absolutely.
Steroids in this case?
Yes. That name is stuck in our heads. And the next time I see it on the list, I'm like, oh God, let's see. What's the vision today?
No, quite true. I agree with that. Nice collection. Very nice collection.
Thank
in each one of that, I think most of them would have been infective keratitis. I mean, bacterial or fungal or things like that. Or maybe some strange like nocardia or something like that.
Yeah.
Nice.
Good collection, good documentation, excellent photographs.
Thank you, sir.
Keep it up.
Thank you, sir.
Right. And any particular preference for steroids? Which molecule, which type?
So these days, if I'm fairly sure that the stromal melt is really significant, and if I'm putting a glue-BCL on the first visit itself, then I prefer to use the dexamethasone eye drops that I've started, the non-combination one, because they are a clear steroid, and so that way it helps, and it's a faster acting steroid. So, but otherwise, if I'm not doing a bandage contact lens tissue adhesive, then prednisolone acetate.
Previously, some people used to use dilute steroid.
Yeah.
0.1%, whatever.
So betnosol used to be, 1/10, and
dexamethasone was also available.
So we've seen those in old case files in fellowship, but we have not used it.
Chronic steroids.
Otherwise, then now we have those surface steroids. If you are not sure, you don't want to cause more harm, probably fluoromethalenone works. FML works very well.
I think only dexamethasone is clear. I mean, dexamethasone and betamethasone are clear solutions. The rest of them all are
all milky.
All milky, all suspensions.